to all of you, both the panelists and the audience. Very big thank you for joining us this Saturday evening. This is our first Legends program, Learning from Legends of 2022. As the name signifies, I think it's a really great teaching program, not just for practitioners, but really for students, for all pediatricians, and also for general pediatricians. Because through these sessions, we try to learn from faculties who are real experts in their field. And we look to them to give us pointers and tips on how we can recognize conditions in our day-to-day practice, which may require a little further detailed look, further investigations, and possibly further referral. So I really thank today all the faculty who have agreed to join us in this Learning from Legends program. We today are talking about some allied specialties, that is pediatric surgery and pediatric orthopedics, particularly how they pertain to our general pediatric practices, both office practice and inpatient practice. So thank you to the faculties and thank you, Dr. Shomik Basu, who is the moderator today. And I hand over to Dr. Indranil Chaudhary, our secretary, to introduce the faculties.
Good evening. This is the Learning from Legends, and this Learning from Legends, let me tell you a short history of it. This was conceptualized by our past secretary, Professor Madhumita Nandivanik, and me together last year. And not last year, 1 year back. So we started from then, and after that, the Corona episode had come. This is the 7th Learning from Legends, and we had very fine with it. I mean, we had lots of audience, and this time we are not doing it in a DIP platform. We are doing it in the WBAP platform. So it may not be pan India, but it will be pan West Bengal, no doubt. Today, we have with us very senior consultant of surgery, Professor Partho Pratim Gupta, who is an eminent professor of surgery and a very friendly, I should say, to the students. And we had Professor Nilay Das, also from ICH. Professor Partho Pratim Gupta is from ICH. I don't know, Dr. Nilay Das has joined us? Not yet. Probably he has, some other connection problems in Jharkhand. So Professor Nilay Das may not be here, but he may be anytime joining us. So we have the eminent Professor Partho Pratim Gupta with us. He was our teacher. He is our teacher, rather. And along with that, we have Mitrojit Mollik, Professor. But he's very annoyed calling him a professor because he says I am too young to be a professor now. But Mitrojit is associate professor of pediatric surgery in Medical College, Calcutta. And we have also Dr. Shaumo Paik, who is a very young and dynamic pediatric orthopedic surgeon. And he has devoted totally to the cause of pediatric orthopedics, and he will be renowned very soon. So today we have a mixture of big legends and small legends or growing legends, and the moderator is definitely another legend, Dr. Shomik Basu. He's a legend because he's young, energetic, and has formulated the whole to this episode. So I think that is enough to talk about all our faculties today. Now I hand over to Dr. Abhijit Datta. Abhijit, আপনি আছেন? Dr. Abhijit Datta is our scientific chairperson and of WBAP. Abhijit, please talk a few words about it.
Yeah, thank you, everybody. And this is the first Learning from Legends of this year, and there are 3 more programs to come. And at the outset, we have a very interesting topic, which we generally come across in our day-to-day practice, and sometimes we feel iffy with the problem, what to do. So this is a very interesting topic, and I think it will be of immense help to the office practitioners all over the West Bengal. So I now hand over to the presenter, the moderator, Dr. Shomik Basu, to start the program.
Good evening to you all. Thank you, WPAP, for giving me this chance to sit with the known legends and the upcoming legends. So only one slide for me. So suppose our pediatric office practice is a game of football. So where do we stand? We pediatricians are generally the goalkeepers. Every patient is ours. We are the owners of diagnosis, owners of treatment, owners of prognosis, owners of the final outcome lies with the pediatricians. So we are standing at the back trying to save the goals. Remember, a game is never won if the goalkeeper does not get any goal. So what are the other roles? Our opponents are very strong, very healthy, very knowledgeable. So who are our opponents? The opponents are the patient party, the universal and the all important, all powerful Google. The third is the media and some of our colleagues who have a habit of medical jousting. These are our opponents. So who are our strike players? Our strike players are the strikers are our subspecialty consultants who have already been introduced before this program, before this slide. And who are the final judges? The referee, the NMC, National Medical Council, the medical commissions, the Consumer Protection Case Acts, and finally the courts. So let us start the game of our office practice in specialties. So Parthodar is a main striker. The other striker is joining. He is having technical problems because he is somewhere outskirts where the network is poor. The new upcoming midfielders are Dr. Mitrojit Mollik. He has been already introduced. And the ever youth Dr. Somo Payak, who is a pioneer in pediatric.
Excuse me, Shomik. I think Dr. Nilay Das has joined. Please check out.
Very good. Niloda has joined. Actually, I am seeing the slides. Okay, if Niloda has joined, very good. Mani, can you see him?
Yes, Shomik, we can see
he is on screen. He is on screen, but both mute and not visible.
আচ্ছা ঠিক আছে নিলয়দা, is he audible?
নিলয়দা একবার just unmute করে একটু hello বলবে?
ঠিক আছে, if he has joined, so let us start.
Phone try করছি, you can.
Okay, ছেড়ে দিন. So let us start our game of football. So the first question would be to Mitrojit and Parthoda in that order. The first surgical questions, our game will be played in very simple terms. A surgical questions followed by a pediatric orthopedic questions. So Dr. Mitrojit, a pediatrician is successfully resuscitates a normal newborn. What things should he check to exclude common pediatric surgical problems? Unmute. Is he audible?
Yes. আমি শুনতে পাচ্ছি, আমাকে শুনতে পাচ্ছেন?
হ্যাঁ, এবার শুনতে পাচ্ছি, বলো।
স্লাইড গুলো শো করবেন। নেক্সট স্লাইড। Okay, good evening everybody. Since the baby is resuscitated, so it looks like color of the baby, the respiration, so that we don't miss the congenital diaphragmatic hernia, or then we have to pass a Ryan's tube, preferably a white port red rubber catheter through orally, by which we can exclude the tracheoesophageal fistula or esophageal atresia. Usually there is we found in the medical colleges that red rubber catheter is now it is not available in the NICU or SNC, but it is very much important in case of diagnosis a case of tracheoesophageal fistula or esophageal atresia, because we have to take a straight X-ray and lateral X-ray of the neck and upper chest including the upper part of the abdomen. After putting a red rubber catheter, either by mouth or by nose, and it will demonstrate that the tube could not be negotiated beyond the upper part of the esophagus, and that's why the diagnosis should
Nana
be
Mitrojit, just tell me the checkpoints while you are resuscitating a baby. What should a pediatrician see to exclude surgical problems? Don't have to explain the process right now. Just কি কি দেখতে হবে?
হ্যাঁ, প্রথমে তো ওটাই বললাম, ট্র্যাকিওসোফিজিয়াল ফিস্টুলা আছে কিনা দেখার জন্য ওরাল একটা রেড রাবার ক্যাথেটার পাস করতে হবে। যদি ওটা পসিবল হয় তাহলে we can exclude the esophageal atresia or trachyesophageal fistula. Next, we have to look for the anal opening and the urethral meatus. If the anal opening is present or not, if it is present, where it is situated. It is in the normal position, or it is anteriorly placed, or it is inside the, in case of female baby, inside the vestibule. By that we can exclude anorectal malformation. Checking the meatus in case of male patient, urethral meatus, whether it is situated in the tip of the penis, whether it is situated below the penis, anywhere in the perineum or in the shaft of the penis. That's why we can exclude hypospadias. We have to check the genitalia and whether the testes are descended in the scrotum, and whether it is present or not. That's why we can exclude the undescended testes. And while the baby is crying, is there any swelling in the groin? It will indicate that there may be possibility of congenital inguinal hernia. Sometimes we see that both the scrotum, both the hemiscrotum is swollen up, and most commonly it is confusing whether it is hydrocele or hernia. Usually hernia, there is impulse in the in crying, but hydrocele just swelling inside the hemiscrotum, both hemiscrotum or either one, and it will not increases during crying. That's why by that we can exclude the hernia or hydrocele.
Okay. Parthoda, any for a quick head to toe assessment, what things we should not miss for a pediatric surgical problem?
See, first thing is that you must ensure that all the apertures or the openings of the body that we are born with are patent. That also includes passing in a small caliber nasogastric tube to rule out choanal atresia. And rest, whatever Mitrojit said is true. A quick assessment would be that from the pediatric neonatologist side, if it is all right, the resuscitation, as you already said, these are the openings. I believe that the apertures must be inspected first.
Okay, for pediatrician, young pediatricians, one more thing. Always put a finger inside the mouth and palpate the behind the palate. If you should not miss a subcutaneous submucous cleft palate. So that is what we pediatricians actually tell us. So next question would be ortho. The same pattern, a pediatrician successfully resuscitates a normal newborn. What things should he check to exclude common pediatric orthopedic problems? Somo, please start.
The orthopedic problems are not that difficult. It's just simple 3 words: look, feel, and move. Look is the inspection. Just need to see all the upper limbs and lower limbs, so this is looking normally or not. The feel is the most important part, is the Otolani and Barlow test. There's a most commonly missed test which can be cured completely by just a harness, that is a DDH that come later on. So feeling of the hip joint and movement of the hip joint is very much important. And we always check other movements also, like all the joints, like hip, knee, ankle, and the upper limb, shoulder, wrist, and elbow. And don't ever miss the spine, because many things are hidden over there.
So I'll start the video. Could you just explain it briefly?
Yeah. So this is Otolani Barlow test. Barlow means Bahar. We are doing abduction. There is a Barlow. In abduction, we try to reduce the dislocated hip inside. And the second step, we are doing the adduction. Adduction is Otolani means in. And the in, we're trying to do adduct the hip, we try to dislocate it outside. So this is called the Ottolani and Barlow sign, and you can feel a click. If you find a click, then it should be treated carefully, because the DDH can be cured completely by giving a public harness at birth. And one more thing, this DDH or public harness, this Ottolani Barlow test should be recorded and should not do it repeatedly, because this Ottolani Barlow test can make the hip painful. DDH is a painless disease. If it's a painful, then you always have a suspicion of a septic hip. So this test should not be repeated and should be done and recorded.
So first so your advice is check all the joints, check all the limbs, and absolutely do a Barlow and Ottolani test only once during your first inspection of the child.
Yes, and don't miss spine.
Okay, fine. So our next question to the surgeons would be, Parthoda, you have
Yeah.
diagnosed cleft lip and palate. What are the red flag signs, if there are any? Any special measures to be taken by the mother during feeding of the child? And when does a pediatrician refer the child for surgeries? And when are the corrective surgeries done?
Well, the red flag signs actually are to see if there is any associated syndromes, because cleft lip and palate usually are non-syndromic, but a few will be syndromic. Syndromic means, to give you an example, Peri-Robba syndrome, or if there is Apert syndrome. So retronathia in your Peri-Robba syndrome is one. Cardiac anomalies, syndromic Aperts, etc. Now, the mother should be taught to feed the child with a spoon or a dropper, even with expressed breast milk. Though in the Western world, they believe that they can feed the child with a long nipple attached to a bottle, and if it is a unilateral cleft palate, then pushing that nipple to the wider side of the palate and suck it. But in our country, unfortunately, as we all know, that these conditions are much, much more prevalent in the lower socioeconomic class, and they don't have that time. So ultimately, the nipple gets stuck in the gap, and the gap starts increasing, or in other words, they cannot just come closer at the time of operation. Now, we do cleft lip at 5 months age or 6 kilograms weight. Now, you can refer the child at 5 months, provided you can ensure that the child is spoon-fed, or in Bengali terms, jhinuk, or anything. The child will not suck. That habit should not be there. You can refer at 5 months for, with 6 kgs weight for the repair of lip. We do the palate at 9-month age with 9.5 kilograms weight. Now, if we find a unilateral cleft lip and palate with reasonable gap, then if the child comes to us around 7 months of age, I personally prefer doing the lip and palate together at 9 months age. Better to refer the baby. As I said before, we can show the post-operative photographs, both immediate and long-term and short-term. This reassures the parents, since a lot of the mothers have a disconnection with the baby because of social problems when they have a baby born with a cleft lip or palate. So that is the only reason that you may refer the child early, so that they know the future is absolutely a normal child in more than 90% of babies.
So take home point is diagnose early, refer early, and remember all these feeding advices by Parthoda is for cleft palate patients. Cleft only isolated cleft lip patients do not need any special care. Most probably, Parthoda, I am right?
Yep, absolutely right.
Okay. So thank you so much. So if Niloida is there, Niloida can take these questions, or Somo will take. How does a pediatrician check the stability of hip at birth? হ্যালো, নীলয়দা আছেন? নীলয়দা? Okay, Somo, go on.
So I have already said that the methods of checking stability test is a Otolani and Barlow test. This is the important test. And if you find any suspicion or any click, or you have any difficulty on the Otolani Barlow, Barlow means Bahar, you're trying to do a abduction, if you cannot reduce it, or you find any click, there is something is wrong in the hip joint. So always do ultrasonography of the hip joint. And there is some suspicion, some cases you can do some suspect. If it's a firstborn female child with a breech presentation, family history of DDH, or any packaging disorder, that means multiple pregnancy, some fibroid in the uterus, something like that, you can suspect that this patient might have a DDH. Overall, if you find a click, then always do a USG first and refer the child to the pediatric orthopedic surgeon, because majority of the DDH patients can be cured completely just by using public harness. If we don't pick it up early, then it will cause a permanent disability, and later on we can also treat the child, because these patients need exhaustive surgery. We don't have a universal screening program, hip screening program by the orthopedic surgeon. So all the DDH diagnosis depends on the pediatricians only. So be careful, and please always check the hip joint to get the patient out of morbidity of DDH permanently.
So the take home message is learn Otolini and Barlow well, do it under supervision, do it more, don't do it more than once. If you find a defect, there is no role of X-ray at all now in DDH. So there is only USG hip. Find a good person who can do an ESG hip to give you the diagnosis of DDH and refer early. And it is completely treatable if referred early. So this is the public harness Somo was talking about. Anything to describe about this, Somo?
This public harness is a little bit difficult because you need to know how to use it. So it can be individualized into train the parents, because this public harness need to use for next 6 weeks to 12 weeks. It's a long time. So it is already under control of pediatric orthopedic surgeon. But you should know this, there is a belt called public harness, and patients can be treated. Non all DDH, majority of the DDH can be treated by this public harness.
Okay, fine, thank you. So Partho, the newborn has been diagnosed as an esophageal atresia by the pediatrician. So what are the red flag signs, and when do you refer, and what is the corrective surgery recommended?
The first red flag sign would be whether the child have aspirated or not. Now, only esophageal atresia, first thing we consider is having passed in, as Metrojit said, a number 10 French red rubber catheter through the mouth and taken, an AP, X-ray, or the babygram. Babygram is required to see for two things. In the babygram AP, you can see the level of the atresia, more so with the lateral film, and more importantly, the condition of the lung and a pure esophageal atresia like blind both ends, where you won't find any gas shadows in the abdomen. Now, if the child has a normal color, then it saves a lot of problem. If diagnosis is confirmed, they should be referred as early as possible with a bulb sucker to the mother to suck the salivary secretions, pooling into the upper blind pouch and then rolling on to the trachea. Now, the surgery is the answer, but the opinions have changed since we were trained. We do not do a surgery as soon as we see the child, not in the middle of the night. We resuscitate the baby properly with a sump suction while in the NICU, and then we see whether it's esophageal atresia with a tracheoesophageal fistula, which is the most commonest type, or it is a rare one with double blind pouch. Now, the approach these days also is changing fast. You can do it in a standard operative way, like an open surgery, but a thoracoscopic repair is nowadays a very good option, because in the long run, when we do an open operation, when these kids grow about, say, in the teens, they have a gross deformity of the chest wall on the right side. So preferred treatment is not right after we see the child as a surgeon. The preferred treatment is first resuscitation and then operation. If it is both blind end, then of course a primary repair is not possible. What you do is a cervical esophagostomy and a gastrostomy, and then replace the esophagus with a colon later in life, that is around 6 to 8 months.
So those who have not done their duty in ICH, always remember a babygram is a complete X-ray, a total a single plate X-ray covering the neck, the chest, and the abdomen. If I am not wrong, Parthoda, please correct me.
Absolutely.
But
Absolutely.
this is not, I have not seen it done in other places, but we are from ICH, so we know it. So a babygram is what is needed. That is a learning point for the upcoming pediatricians and the pediatricians who have forgotten or have developed gray hair like me. Mitroji, do you have anything to add?
No, sir. Sir has
সাড়ে দশটার পরে ফোন করো,
every
কনফারেন্স আছে।
aspects of that.
আপনি সাড়ে দশটার পরে ফোন করো, কনফারেন্স আছে। So we move on to the next slide. So if Niloida is present, Niloida can answer. Niloida, so let me start the question itself. The pediatric consultant diagnoses that the newborn has Talipes equinivarus. So when do you need an ortho referral? Do you need to refer the orthopedician on the day 2 itself? And from pediatric orthopedicians, we need to know what are the latest treatment options. So if you diagnose DDH and TAV, do you need to look for other congenital abnormalities? I think Niloida is not there. So Somo, carry on.
So first of all, when you need to do a referral on the CTV patient, so CTV means congenital Talipes equinovarus. So majority of my referral of the TB patients are not CTV at all, because you do sometimes overdiagnosis, sometimes you do misdiagnosis.
So explain to the audience what is actually CTEV according to you.
CTV is a CTEV. There is a E word called equinus. Equinus means ankle cannot be dorsiflexed. If the forefoot is bent, forefoot bent does not mean CTEV, because postural forefoot varus is a normal physiology. Because the space crisis, the foot is bent sometimes in children. So after so this is like this. If the foot is bent, suppose foot is bent, just like a bent foot, then bent foot does not mean a CTEV. Bent foot, majority cases, this is a postural forefoot varus, which does not need any treatment. So eventually, it gets corrected by 4 to 6 months time. But if the patient's ankle cannot be dorsiflexed, then it is definitely CTEV. This E part is very important. If it is cannot be dorsiflexed, then definitely you should do a referral to the pediatric orthopedic surgeon. CTEV treatment is not an emergency treatment or emergency plaster, emergency surgery, but you should start early. The problem happens if the baby is premature. Majority of the premature babies has a tendency of a carved foot. So preterm babies, if the birth weight is low, so there is no urgency to rush for the CTEV treatment. Let the baby healthy. We usually start CTEV treatment after 10 days and the birth weight more than 2.5 kg body weight. There is another important point, because we frequently see a prescriptions that massage by the mother in the pediatrician prescription. It is a great mistake done by the orthopedic book Maheshwari in our MBBS curriculum, where they have written the massage by the mother is the treatment of CTEV. This is absolutely wrong and not followed in any textbook, because What we advise the mother is just the forefoot abduction. Just do this. This forefoot abduction is not the treatment of CTEV. On the first cast, we do forefoot supination. That means aggravation of the deformity. Gradually, we decrease the supination and increase the abduction. So this is classical Ponseti method. It cannot be done by a mother. So sometimes we get some crooked foot after the mother's manipulation. So mother's manipulation is not the treatment. You don't touch the baby. Let the baby gain the weight, at least 2.5 kg body weight. And after 10 days, because initially the skin are very thin and there are plaster rashes, etc. So preferably after getting the baby discharged from the hospital, and we start the treatment Ponseti. Ponseti technique is universally accepted. We usually do 4 to 5 to 6 casting, weekly plaster, followed by a small surgery called tenotomy. And after the plaster and tenotomy, this foot is completely corrected. The problem starts at that point only, because the purpose of the CTEV treatment is not doing the plaster and tenotomy only, because plaster and tenotomy is a half of the treatment. Then we give brace, special brace, both the shoes joined with a bar. Individually, different shoes has no role. The shoes should be joined with a bar. These shoes should be used for up to 4 years of age. That is the biggest problem. So the purpose of the shoe is to maintain the corrected foot for 4 years of age. So that is why the patient should be counseled well. You need to go a long run for 4 years. Initially, there is some aggressive treatment, plaster weekly, followed by a small surgery, and then the shoes. You can see the picture in the overhand. So these patients looks like a CTEV. The forefoot is varus, but this is not a CTEV. You can see the ankle can be completely dorsiflexed. Usually, ankle dorsum of the forefoot can touch the anterior aspect of the leg in newborn. So that is why this is not a CTEV, but this is a CTEV. So that should be cleared. And once you have a CTEV diagnosis, this must be ruled out whether it is a CTEV is a congenital talipes equinovarus. C for congenital, that means a idiopathic variety. There are other terms called neurogenic CTEV, neurogenic TEV, in which cases patient has a bent foot along with a knee deformity, hip deformity, spinal deformity. So when you get a CTEV or TEV or forefoot bent patient, you must check all the joints properly to rule out other deformities, especially the hip joint. You don't miss a hip joint, because TEV and DDH are frequently associated together.
Thank you. So the first learning point would be the child whose foot cannot be dorsiflexed is actually CTEV. Second is there is no hurry, there is no need for massage, and you can definitely send the baby to the pediatrician after the baby gets discharged.
One point, which no hurry means does not mean you send the patient at 6 months, because
No,
it's too late.
After discharge from
After
the
discharge,
hospital,
not
definitely the child will
because
go.
we see
But
also
during admitted at the hospital, there is no urgency that the pediatrics orthopedician to be referred right now. So you can safely refer the pediatric to the orthopedician just after, but by writing it in the discharge summary, most probably.
Yes.
So Mitroji, this is a common problem faced by pediatricians. It is not a very serious problem, but it is a very common problem. I know Parthoda might have been called numerous times. We also in a dilemma, because this is a cosmetic problem and parents are very worried about it. So during nursery stage, the pediatric documents an extra appendage of hand and foot. Sometimes it is an additional appendage, sometimes it is a hanging appendage by a small vessel-like structure. So what does the pediatrician has to be alert? Does he has to be alert of something wrongdoing? Does he have to really call a surgeon immediately? And how does the surgeon decide what he shall do with the extra appendage?
Sir, I have already told you whenever the question was put that if the attachment is just a thin layer of skin or vessel.
Would you be a little louder?
Sir, if the appendages are attached with the main torso by just a simple skin or blood vessel, then it is usually managed by the pediatric surgeon. We can manage it. But if the attachment of the appendages with the torso is by a bony structure, we usually prefer the it is preferably referred to the plastic surgeon or orthopedic surgeon. কি একটা চামড়ার স্কিন থেকে একটা অনেক সময় আমরা দেখি যে একটা সুপার নিউমারের ফিঙ্গার একটা ঝুলছে, হ্যাঁ, ওটা ইউজুয়ালি অনেক সময় টর্শন হয়ে গিয়ে নেক্রোসিস হয়ে নিজের থেকেই পড়ে যায়, আবার অনেক সময় পেনফুল হয়, ইডিমেটাস হয়ে যায়, তখন সার্জনের কাছে
In our old days, some surgeons used to say tie a. I know Parthoda will laugh, but tie a black silk and the finger will drop after 4 or 5 days. Is it really needed? হ্যাঁ, মানে ওটা কি করা উচিত? কেউ কেউ আমাকে বলেছিল it will call avascular necrosis sometimes if it is the feeding artery, and it might cause more complications. Then it is better to avoid such advice, is it, Parthoda?
Yeah, of course, because all that you need, you have to understand the days have changed even when you were student and trainee. Now, if a baby is born with an extra, finger in the hand or the feet, first thing is that you have to check. Normally, it's usually on the underside of one hand, rarely involving both hands and the feet. Now, apart from that, what Mitrojit said, that yes, if we have that as a small connection with subcutaneous tissue with, hanging right, it is better because it takes only 2 minutes. And I normally prefer doing it under local anesthesia and, bipolar diathermy. It's just a 2 minutes job. Because wherever you are trying to induce a kind of necrosis, somehow I feel that should be avoided. And if it is a bony one, sometimes it's very complex and should rather be done not by a plastic surgeon, but by a hand surgeon. Okay?
Okay, thank you, Parthoda. So, always, if there is gross polydactyly or multiple fingers with malformation, always check for congenital anomalies. So if it is a cosmetic procedure, it is better to call a plastic surgeon than a pediatric surgeon per se. So, and if the parents do not have any problem with that additional appendage, then it can be decided whether the child wants to remove it or not in the adult age. So that would be the summary of that one. So now, Somo, a newborn suddenly develops persistent crying and the mother notices pain on handling one leg. So what could this situation be? Should we be really very afraid for this situation? And how do we investigate, and what is the role of a pediatric ortho?
This is very alarming. If some features appears like that patient baby is crying on handling one limb, then until unless proven otherwise, this is a septic arthritis of the hip joint. Can you show us the video I have sent? Because very important, I need to show this, or I can share screen from my side. The video, Shomikta? Yeah. For this child, you look at the left hip joint, left side of the limb. So left side, the baby is not moving the limb at all. The hip is flexed, abducted, and external rotated. This is a classical finding of septic arthritis of the hip joint until unless proven otherwise. So hip is, I'm again saying, hip is flexed, abducted, and external rotated. And on touching the limb, this is a painful. Frequently, mother complains that during changing of the nappy, baby cries. In septic arthritis of the hip joint, in a preterm baby, there might not be any fever. Patient might not have a high CRP count, but still, until unless proven otherwise, this is the septic hip joint. Septic arthritis of the hip joint, the diagnosis is firstly and foremost is the clinical findings, clinical suspicion. There is no harm to do a over treatment and over diagnosis rather than a missing a septic hip, because septic hip is a really emergency. Once is from infection point of view, and second is cause a permanent avascular necrosis of the femoral head. What is the ideal diagnosis? Ideal diagnosis is a different to the blood test, CBC, CRP, we see the markers. Ultrasonography is the gold standard of this for septic arthritis of the hip joint. But problem is ultrasonography. This is the small baby USG, not that easy job. Majority may not be well associated with it, but still USG is the choice. If possible, MRI can be done. But again, MRI in a small baby, you need a very specialized setup. But if you can do a MRI, then you can see the hip joint and pass inside it. Now, if you have a blood report in hand, blood culture, or USG in hand, what should be the management of septic arthritis of the hip joint? So there are a lot of controversy I have seen, because I have personally had a lot of controversy with the different pediatrician, because majority, not majority, there is a good portion, they have a tendency to treat the septic hip by IV antibiotic only. Even in the Nelson, your pediatric textbook, it has been written that this is a surgical emergency. Why surgery? Because if you do by IV antibiotic treatment, infection will subside once at some time, definitely. But the pus causes the pressure inside the hip joint, which causes permanent damage of the head, or that is called Tom Smith arthritis. The femoral head is completely gone. So we need to release the hip joint pressure. Preferably, septic hip should be opened surgically. You should open the hip capsule, release the pressure, and then on control give access to, you should have a good access with a good pediatrician who can maintain IV antibiotic later on. There is a lot of controversy how long antibiotic should be given, IV antibiotic versus oral. There is no fixed guideline. After septic arthritis drainage, some people say 2 weeks IV antibiotic, some people say 6 weeks antibiotic, because we have seen. But if it's a neonatal osteomyelitis septic, preferably, probably, because you can say better, IV is the only choice. You cannot control, you cannot rely on oral antibiotic. So if it's a neonatal septic hip, you have to give IV antibiotic for 6 weeks. If it is a pediatric case, not neonatal, elderly child, then there are a lot of papers, because in the Western world, they have also increased burden to wrong run and running the antibiotic. So they have recently coming up new papers. If the patient is symptomatically asymptomatic, if the patient's CRP count is less than 50% of the pre-op CRP count, patient must be asymptomatic, patient must be painless, and CRP should be reducing at least 50% of the pre-op value. Then only you can convert to the oral antibiotic. But this is not a dictum. We can follow it or do not follow. That is your choice. Another point in septic arthritis is that aspiration can be done. Aspiration is practiced many places. The problem of aspiration is sometimes septic hip is bicompartmental. If you do a septic aspiration, you get some pus, you are happy, you are missing the other compartment. Number one. Number two, aspiration can be done, but ideal treatment of aspiration, it should be image guided in a sterile environment, and it should be repeated, which is a much more costlier factor in our region. So that is why better not to go for aspiration. You go for open drainage, release the pressure, release the pus, go for a culture and tip culture, and always jointly admit with some pediatrician and start the IV antibiotic.
Okay, so the take home points is septic hip. If you diagnose, it is easy to diagnose. It will be painful. There might be fever, but it will be painful, and the hip will be, there will be less movement on that side. It is a surgical emergency. Do not try to tackle with it medically only. Always refer to a pediatric ortho, because if there is an AVN and there is destruction of hip in later life, you will be in a terrible soup and medical legal problems, and you will be held under criminal negligence. So that you always remember. So thank you so much. We'll keep the slides, our comments a little shorter. So Parthoda, this is a very common problem. We'll only focus on the larger issues. So if we see numerous babies with such features of various forms and shape, these are the hemangiomas. We are more worried about the cavernous type of hemangiomas or the florid or large capillary hemangiomas organs. So when should a pediatrician be really alert and alarmed with a hemangioma? And which are the dangerous forms and what are the latest treatment options? Parthoda?
We all know there are slow flow and a high flow hemangiomas, and it's basically, rarely are they dangerous, excepting in certain places. One, on the lid and the face, where the capillary hemangiomas can give rise to something like elephantiasis. In the limbs, at times it can give rise to gigantism and the parotid region. Now, I remember that in the parotid region, when we are trainees MCH, the dictum was to operate. Nothing was available. And perhaps more than 80% of the children had a facial nerve palsy on that side. Because if you want to excise the hemangioma, then this was the consequences. So now what we do is that if it's a capillary hemangioma, long time back it was seen that steroids like prednisolone works wonders in short burst high dose therapy. And then we have the option of propranolol, and with or without prednisolone. Now surgery, yes, we do surgery especially for cavernous hemangiomas, because no matter how grotesque it looks like, the cavernous hemangiomas can be dealt very easily by surgery. And the other forms are in minimal invasive embolization locally for the hemangiomas, and large, like if you can do it specially, if you have the hemangioma, especially in the liver and spleen along with somewhere, then it becomes a red flag sign. I think that whenever you see a hemangioma in the facial region above the level of the eye, please take a MRI, MRI angio, yeah, to find out whether it has gone inside, intracranial extension or not.
If there are other AV malformations associated with it. And other thing is what I have seen a very dangerous form is if you see large hemangioma over the neck or in the oral cavity, always do a MRI angio of the neck, because you see larynx, hemangioma of the larynx profusely bleed. So they have to be reduced in size, and then they have to be operated, because they are very dangerous and they will bleed you to death. So those,
actually, that's the reason why the embolization comes in these days.
And nowadays for large hemangiomas or capillary type hemangiomas, newer treatment have come, is timolol drops have come in. So yes, that is a good option. That they please take care of the dosage. It is written in the standard textbooks now. So Somo, this is a common problem, very common problem, and parents get very agitated with it. So father was playing with a toddler kid, probably holding the kid by one hand. Suddenly he pulls, and suddenly one click noise comes from the right hand, and the child starts crying. So the baby is showing some problem at the right wrist. Entire right upper limb looks like paralytic. What do we do as a pediatrician?
This is the one of the conditions where you should not panic at all. This is the least harmful condition, but parents are very much anxious because the limbs look paralytic. The baby cannot move the limb, and they think are huge matters. Something is the elbow is fractured or something like that. But if the parents said, usually toddler patients 1 to 3 years of age, and typical history, the pulling of the forearm, pulling by the wrist, or holding the baby like this, sometimes then playing like there's a click noise. And the problem lies in the elbow joint. Baby shows a wrist joint. This is called referred pain. Usually the problem is not at the wrist, but the problem in the elbow. Two things might happen. If you're a pediatrician, patients come to you with a panic and there is a click for the noise. First, look for any obvious swelling. If there is any fracture, there must be some swelling, whether at the wrist or at the elbow. If there is no swelling, and if you have history pulling by the hand and there's a click, unless or until proven otherwise, this is a pulled elbow, and no need to panic at all. There is no harm, then there is no need that you have to reduce it within next 5 minutes or next 1 hour or next 2 hours. It can be reduced. You can be reduced by you only, but be sure this is not a fracture. Again, I'm saying, if there is any fracture, there must be some swelling. Again, if it's a pulled elbow, there is no role of X-ray or USG or something else. You need to know the maneuver only. If you hold the hand, you just supinate it. Baby likes like that. You just supinate it and flex it. Supination and flexion, it will reduce. You will again find a sound of clicking sound, and the baby will be painless immediately. If it's a reduced pulled elbow, after that we don't give any medications or any sling or any other else. Only
Okay.
advice that do not do the maneuver again, because if there is a pulled elbow, it will be repeated over next 5 to 7 years of time repeatedly.
Okay, thank you. So, Mitrojit, a pediatrician finds the classical signs of congenital diaphragmatic hernia just during resuscitation. So he's a learned person, he's a trained person, he avoids back mass ventilation, decompresses the stomach, stabilizes, and calls a pediatric surgeon. On what basis does the pediatric surgeon decide on immediate surgery? And what are the signs of poor prognosis even after successful surgery?
First of all, in case of diaphragmatic hernia, most of the cases we see that it is an emergency of the pediatric medicine, not the pediatric, because there may be inherent lung agenesis, and that is the problem. And there may cause pulmonary artery hypertension, and that is the main cause of that is the main red alert sign. Let's say, if the baby is resuscitated and if there is pulmonary hypertension is controlled, then should refer the patient after medically stabilize the patient. You should refer the patient to pediatric surgeon to correct the diaphragmatic hernia or eventuation of diaphragm. Maybe both the left side and right side surgical approach may be open or maybe bronchoscopic. Usually left sided we manage by abdominal route, and on the right side usually approach to bronchoscopic route. And another thing we have to keep in mind that there many of the cases are associated with malrotation. Congenital diaphragmatic hernia, many of the cases are associated with malrotation. That's why we usually prefer the operation through abdominal route. By that we can exclude the malrotation, or if there is a presence of malrotation, we have to correct it in the same sitting.
Parthoda, do you have anything to add?
No,
Okay.
I don't.
Achha. So we go to the next slide. Somo, a 5-year-old child attended your OPD with pain and swelling around the right elbow following a fall on the outstretched hand at the playground. So the pediatrician has done an X-ray, and the X-ray looks like the elbow dislocation. So what to do, and is it in an emergency?
This is a real emergency, but elbow dislocation is a nil factor or null factor in pediatric patients. This is usually supracondylar fracture. Always check the radial artery for the child. If the ipsilateral limb radial artery pulse is absent, immediately refer to a higher center, because this patient might need a neurovascular repair. If there is radial artery pulse is present, then also you need to put a slab or plaster immobilization and seek for a ortho referral. If you cannot manage with the plaster management, then send to any nearby orthopedic surgeon for put up temporary plaster and manage it perfectly.
Okay. So these are the salient points. So if you can say, Somo ekটু বুঝিয়ে দাও বাবা.
So this looks like a elbow dislocation. Whenever I get a patient, pediatrician called a somewhat of elbow dislocation hoiche. So this is not, this elbow is in this region. This is the supracondylar fracture region. This looks like elbow dislocation, but this should be treated as early as possible.
Okay. So Parthoda, a newborn, this is a common problem. A newborn persistently vomits 7 days after birth. Otherwise, the child is stable and feeding. What does a pediatrician need to do before calling a surgeon? What are the points that suggest that the child has a surgical cause? what are the red flag signs that the pediatrician shouldn't be aware of? And then what are the surgical problems anticipated and our surgical options?
You see, the number one is that if the child vomits at 7 days of age, you have to look for the color of the vomiters. Because if the vomiting that occurs is non-bilious, then I don't think you should be bothered about any, surgical problem. It'll be very, very rare to have pyloric canal atresia. Now, if the child vomits bilious, that's where we are concerned. And if the pediatrician is happy that there is no septicemia associated and there is a bilious vomiting after feed, then the first thing comes to our mind is an upper intestinal obstruction, of which the most common is duodenal atresia, or including all the varieties of annular pancreas and windsock deformities. And the next that we have is malrotation of the gut. Now, the malrotation of the gut and duodenal atresia at times give a similar picture of a double bubble shadow because of the band of fat crossing over the second part of the duodenum. Now, anything lower down with persistent or repeated bilious vomiting, like if you are thinking about ileal atresia, it can very rarely, if it is an incomplete atresia. So we are more concerned with these two, whether it's a duodenal atresia or malrotation of the gut.
Just another question, congenital pyloric stenosis, can it present early and can it present late?
Yes, it is no more called a congenital pyloric stenosis. It's called an idiopathic hypertrophic pyloric stenosis. Usually it can present itself around 3 to 4 weeks of age, but it has been seen at about 3 months of age too. But that is very rare.
Because I remember you diagnosing increased pyloric tone and we did not, you refused to surgically. Yes, it was a friend of colleague of ours, a junior of ours. So can you describe that condition in a few words for how do you differentiate between the both?
Well, you see, if it is IHPS, it is clinically evident. Clinically evident as repeated forceful non-bilious vomiting after feed or immediately after feed. And second is, as soon as the child vomits, child is voracious to have another feed. Third is, when you see the child, the best way to see the child and examine is by keeping the child in the mother's lap while being fed, and pass your left hand right in the subcostal region on the right side and try and feel a kind of a mass. It's not called a lump anymore, where you can always see a visible peristalsis in the upper abdomen ending. And if you can feel a mass or lump, which actually feels like as if you're feeling the tip of your nose under a blanket. If you remember that, that is something confirmatory for IHPS. Now, if the vomiting is being complained of, which more or less, looks like to be IHPS, get into a detailed history and you'll find that it is not persistent. Maybe it's due to overfeeding or due to a pylospasm.
Thank you so much. So, Somo, a pediatrician resuscitates a preterm baby and sends it to NICU. After 3 days, he or she notices that the left knee is kept folded by the baby all the time. On examination, the left hip movement was also painful. What do you do?
I have already said that similar features like left hip and knee movement painful and folded. There is no fever, is usually until unless otherwise septic hip. One more thing, in a preterm baby, it might be if there is a gross swelling over the thigh, it might be a femur fracture also. So if we see a gross swelling of the thigh, we just do a X-ray to rule out femur fracture. If there is no femur fracture, then it is unless otherwise proven otherwise, this is septic arthritis of the hip joint and treat it accordingly.
So any painful joint or any painful joint with limitation of movement, be very careful, pediatricians. That is the message. So Parthoda, this is one of your slides. So we have come down from above downwards. So a newborn presents with red testes. So this is a common problem. And is this an emergency? Are all red testes emergencies? How do you investigate? How do you differentiate?
Well, number one is that I would suggest that every testis or the scrotum, if it is red on one side, should be taken as an emergency. Though it may not be torsion, it could be mostly acute epididymoarthritis, but it should be taken as an emergency, and especially acute epididymoarthritis is not that common below, say, 1 year of age. So as soon as you see a red testis, do a USG Doppler study, see the vascular pattern. If you don't have that facility to have an access to a Doppler, refer it to a surgeon. It is much better to operate, see for yourself, than to lose the testis, because if you operate after, say, about the 6 hours in the total history, the chances of survival, salvaging the testis, is very, very poor.
So pediatrician,
and of course, this is interesting because if you have a newborn with a red testis, that is one side, which is hard, please think of a yolk sac tumor. It may not be a torsion at all. That is the reason a red scrotum should always raise the red flag. Okay?
Absolutely. So red stands for danger, and for pediatricians, one salient point is do not write only ultrasound testes, a testes or scrotum. Do write a Doppler study as well. That is missed by some, and usually if you don't write, they don't do. So, but okay, experienced sonologists always do. But your ideal prescription, anything in the red, anything red in the scrotum should be a Doppler study of that side of the scrotum. So please remember that. That would be more helpful. So alpha fetoprotein একটু বলে দাও Parthoda. Just a marker of
is yolk sac tumor, and at times it goes up to more than 1,500. So, you know, like that's just something that you need to do for two reasons. One, for diagnosis, and B, for follow-up, so that you know that the tumor is not more there in the body.
Absolutely. Somo, a 5-year-old child presented with pain in both the legs, aggravates at night and relieved after massage. Visited multiple doctors without result. Do we need to refer to a pediatric ortho?
You need to refer to pediatric ortho because you need some relaxation. These parents will come to again and again. Bilateral, any orthopedic issues, if it's a bilateral and it's a diffuse, it is usually not that much severe. Bilateral leg pain, usually in the calf pain at night and relieved after massage, age group between 4 to 7 years of age, is usually growth pain, unless or until proven otherwise.
Tell me one thing, we haven't found it in pediatric practice, but is it written in your books there is an entity called growth pain?
This is called growth pain. Yes. Because of 4 to 7 years age, there might be some issues and the bone pathology, vascular pathology. For that, you might have this problem, but there is no exact cure is written in the textbook. Some doctors suggest that you use a vitamin D, and even you have no
relation. That was the other question we are coming to. Any leg pain, do we do vitamin D3 levels?
So it is not established that vitamin D is the cause of this leg pain. And this is self-limiting. It will go on after 4 to 7 years of age. And massage is the best treatment. And parents might ask that which oil massage. You tell whatever favorite oil you have, and ask just a massage, and it will be relieved over gradually. You can give a paracetamol also,
Yes.
which is severely painful.
Yes, absolutely. So it usually occurs in the evening after the child comes back from play, and usually during the night. A light massage or a light relaxation with a paracetamol is good enough. And it is actually explained that it is sudden stretching of the bones and the vascular pressure, though that pain is occurs. So now both we'll start with Parthoda and we'll go on to Mitrojit. The mother comes back to the pediatrician with a discharging umbilicus. Now umbilicus is a very debatable thing with pediatricians and mothers. So you can have multiple things. And how does a pediatrician diagnoses the multiple umbilical disorders, at least the physical ones? Usually you have a red mass or a mass which is discharging at the umbilicus. So Parthoda, what are the conditions possible, and what must the pediatrician do to diagnose the ailment, and when does he call a surgeon?
Basically, you see, a discharging umbilicus not necessarily would have anything reddish at the umbilicus. Reddish with discharge are usually umbilical granuloma or an umbilical polyp. And if there is no redness, but there is a discharge which is sticky and it, usually around the umbilicus, rule out patent urachus. Now, so if you have a granuloma, it is rough surface, even if it is a kind of a globular swelling. But if it is a polyp, it's a cherry. It's just a cherry. Now, when you have a granuloma, then you can use anything, and that usually resolves on its own. But if you have a polyp, then using triple dye, or in olden days, the silver nitrate, usually never works. All that you need to see is if there is a pinpoint opening at the summit of that polyp to rule out any kind of intra-abdominal extension, whether it is a patent tube or it leads to a blind sac and stuff like that. Now, clinical diagnosis is the only diagnosis that you can do. And if the lesion persists, then we do the operative interventions. Rarely would we need to do an operative intervention for an umbilical granuloma. Just reassurance to the parents are enough.
And the one thing, always remember, if there is discharging, I don't know whether we should send it to a pediatric surgeon. There may be a fistula or a vesico-umbilical, which we had patent urachus.
That's patent urachus.
So Parthoda, তোমরা এখন কি করো? এখনো কি ডাই দিয়ে করো না গ্যাস্ট্রোগ্রাফি ইউজ করো? মানে I don't know what.
Actually, I do not do any contrast study at all.
Acha.
Because I operate through the umbilicus. So basically, there is no scar whatsoever, and you keep.
How do diagnose a patent urachus?
Patent urachus is, if you really want to, then you have to do a contrast study of, rather a cystogram. It's much better to do, or a contrast MRI, because not all, patent urachus, as we say, the patent urachus are really patent to have urine coming out from the umbilicus. It's a mucus discharge of the patent urachus actually what comes out. Very rarely would you find that urine is coming out from the patent urachus. So
I've only seen one case that was given to me at NRS at MBBS examinations. It was horrified. We never saw patent urachus in my life ever again. So that too in a larger child. So granuloma, either chemical cautery or electrocautery. Mitrojit, do you have anything to add?
Patent urachus may be associated with posterior urethral valve. One of the pop-up mechanism.
জোরে বলো, তোমার না ভয়েসটা ভীষণ জাম্বলড আসছে।
স্যার
নয় ওটাকে দূরে রাখো নাহলে ডাইরেক্ট বলো।
patent urachus
হ্যাঁ,
may often
better.
can be associated with posterior urethral valve. It is one of the pop-up mechanism for posterior urethral valve patients. So, as said, already told that umbilical discharge uh, may be due to a patent vitalointestinal duct or patent urethus or umbilical ganglion, etc. Umbilical sepsis may cause some purulent discharge, usually due to culture and sensitivity of the pus. We used to do a high resolution ultrasonography of the umbilicus and anteroabdominal wall to exclude any patent tract. Either it may be form of urethus or patent VI. Usually, surgical option, if the discharge is persistent, we usually prefer to explore the umbilicus. It is better to check through a small incision, a smiley incision under the umbilicus whether there is any communicating tract or not.
Okay, we'll discuss the surgical aspects later. Okay, mane we'll not discuss surgical procedures over here. Okay, thank you, Mitrojit. Somo, people might be wondering why I'm calling Somo every time, but he is now like Lord Krishna and he is actually helping us because Niloida could not connect to us. So every time we are in problem, we are calling Somo like Lord Krishna. So Somo, 5-year-old child presented with 3 days of severe leg pain. So I have experienced this condition from 2 patients of mine. I know what they have done. There was no way of is a nice child, is a good family child. So, but there was only a mild low-grade fever for the last 1 day. The X-ray looks normal. What to do?
This is a different question from previous patient. Previous patient had a bilateral leg pain. This is a unilateral leg pain. If you have a unilateral disease, unilateral pain, there is something else. This patient has a unilateral leg pain, severe leg pain, gradually increasing leg pain, and low-grade fever. Until unless proven otherwise, this is osteomyelitis of leg. You might find that what is the cause of osteomyelitis? We all know that there are different reasons of osteomyelitis, but pain, severe pain, one-sided pain, low-grade fever, this is osteomyelitis of leg. X-ray
Yes,
findings.
And Soma and I would also agree, those who have seen patients with osteomyelitis, the pain is characteristic. মানে যেটা আমরা বাংলাতে বলি কাটা পাঠার মতন লাফাচ্ছে, the pain is very, very painful. It's a very painful lesion. And luckily, surprisingly, the patient might not have fever for 2 or 3 days.
Yes, the fever comes later on, and X-ray is
Yes.
usually normal because osteomyelitis changes in the X-ray comes after 10 days. So what is the earliest
Absolutely.
diagnosis? Earliest diagnosis is the MRI. Is the gold standard nowadays. For septic hip, I said it is a USG, but for osteomyelitis, this is a MRI because you can see there is some marrow edema inside the bone and some periosteal collections. And if there is any collection inside the body, you should drain it by surgically. And after the osteomyelitis of diagnosis, surgical drainage is the choice. Sometimes we use a IV antibiotic also, but after putting IV antibiotic, we see the response. If the patient's pain is not decreasing or CRP count is increasing over next 2 to 3 days, rather go for drainage quickly. I said previously, septic hip, the treatment is open drainage, but osteomyelitis, you might not need open drainage always. You can start with IV antibiotic. If it does not respond in the next 48 hours or increasing gradually, do no harm to go for surgical drainage. But before that, you do all the investigations, CBC, serology, and the MRI also to get the proper location and if there is any parts collection or not.
So the message would be always be aware in a larger child, especially a 10 years, 13 years child presenting with severe leg pain, limping, unable to raise the leg. Absolutely 90% of your first diagnosis should be targeted towards osteomyelitis, and never be afraid to write an MRI of that leg. Sometimes the pain gets referred, the lesion is somewhere else and the child is maybe complaining at the knee. The lesion is at the knee, upper end of femur, but the child complains of severe ankle pain. So always involve two joints and recommend an MRI. You will be surprised to diagnose a lot more osteomyelitis, and it has nothing to do with malnourishment, nothing to do with poor hygiene. It can develop in a well-to-do child in a matter of few days. So we have been warned. We have only 10 minutes more, so it will be very short answers, and let us see how many questions we can cover. Parthoda, how does the pediatrician differentiate between umbilical and paraumbilical hernia?
Number one is that examine the baby in erect posture. If you have an umbilical hernia, it's usually a kind of a globular one, which juts out perpendicular to the surface of the abdomen. A paraumbilical hernia, if you look from the side, always hangs down. And then when you palpate the child, the gap that you feel in an umbilical hernia is at the site of the umbilicus. And in a paraumbilical hernia, which is usually again called supraumbilical hernia, there is a gap above the umbilicus. So these are the clinical signs. And if it is an umbilical hernia that you have seen, say, around 3 months of age, just reassure the parents. The chances of obstruction is less than 1%. They usually resolve by its own by the age of 2.5 years. If still persists, then we can do it. The only exception is in the West, when we work, the parents would like that to be operated because they don't like such grotesque looking,
So
swelling.
Parthoda, what is the safe time for operating if the parents want?
Anytime.
Post 1 year?
Anytime. Anytime. If they insist,
Excellent.
anytime. But paraumbilical hernia, you have to insist that it is operated as early as possible
Yes,
to avoid
absolutely.
obstruction.
So that is what is important for pediatricians for medical legal purposes is please differentiate between a pure umbilical and a paraumbilical, which is called supraumbilical. It's actually a crescent like gap above the umbilicus. So if it is a paraumbilical hernia, always remember for you and the patient party, it will never close. So there is no instance of waiting, telling the parents that দেখো ভালো হয়ে যাবে. So you tell the parents and write it on the EA that this might be a paraumbilical hernia, go to a surgeon, get a referral. So umbilical, pure umbilical, which is very common, usually seen after birth, increases while the baby coughs, cries, and the larger it is, the safer it is. So remember that. Okay. So we have covered. So Soma, very fast, 2-year-old child presented with right-sided limping since he started walking. Mother says that the right lower limb looks short. What to look for?
One line answer: if there is any limp in any orthopedic patient, always refer to a pediatric orthopedic surgeon. There is something else. Limp is always pathological. Don't miss the hip joint. It might be a dislocated hip.
One short question with parents say যে ডাক্তারবাবু একটু দেখুন তো একটা পা বোধহয় ছোট মনে হচ্ছে একটা পা বড় মনে হচ্ছে. One question. Second question যে যখন হাঁটছে বা দৌড়াচ্ছে একটা পা টেনে হাঁটছে, এটা একটু বলতে পারবি কিছু?
ছোট পা লাগছে মানে পাটা ছোট হয়েছে কোথাও থেকে, probably hip is dislocated up, so overall the apparent length is short. If you see the true length, then it's a normal length, but apparent length
just teach us how do you measure true length very fast?
This is very difficult. This is not one line answer. This is orthopedic, pure orthopedic. And if it's a part,
so you will not reveal all the secrets. So
no,
okay, for the next ball.
And if it's a tene hatche means something pain or something else. So any limp is always pathological. Send to orthopedic surgeon.
আমি এখানে একটা শর্ট বলছি, ওর প্র্যাকটিস একটু মার খাচ্ছে, কিন্তু আমি বলবো যে যদি লিম্প হয়, just give paracetamol for 1 or 2 days. If it goes away, then it is gone. If it doesn't go away, send to Stomo. Acha, chalo. The Parthoda, the mother comes back at 6 months of age and complains that the commonest problem on earth for pediatrician, and complains that the preputial orifice is too small as told by her relatives. So what is the difference between physiological and pathological phimosis? When do you intervene and what do you do?
So number one is that you have to look for any blemish in the preputial opening. Because if the skin is supple, usually you can see the external urethral meatus. Reassure the parents. And for you, pediatricians and neonatologists, please don't advise the mother to pull the prepuce back and push it forward right after birth so that this is going, because one must know that this is physiological, because nature protects it from any abrasion giving rise to any urethral stenosis due to contact with the urine. Now, once you have a patient with normal supple skin, you can wait till 4 years. These days, some people say you can wait till 5 years before you decide on doing any surgery for future physical and sexual relationships. But if the preputial opening is hard, yellowish or whitish, which we call BXO, then it is a pathological condition and the phimosis needs to be operated upon. Now with BXO, there is no other way. You have to do traditional circumcision. But if it is at 5 years and the skin is supple enough, then I prefer doing a preputioplasty, which gives a much better cosmetic results and immediate post-operative pain and etc. much less.
As pediatrician, we should be wary of a child who has a phimosis at 2 or 3 years of age,
Yes.
is having recurrent urinary tract infections. I think that is an ideal case for preputioplasty or circumcision.
That is before 1 year of age. If you have a baby with urinary tract infection, once the baby has a urinary tract infection, the male baby, alarm bells ring whether there is any posterior valve or any other urological condition. Now
First of all, I want to give a message that pediatricians, if the child is fine, urinary flow is okay, it is going wide, and don't worry about and don't even tell the mother to touch that area for 1 year. Okay. So if after 1 or 2 years there is a problem, is ballooning a sign for? No,
it's a physiological. The only thing is that if you have a male child below 1 year with urinary tract infection, 2 confirmed episodes.
Less than 1 year ছেড়ে দিন, ধরুন 2 years to 5 years, when do I send this baby for a pediatric surgical review?
As I said, even after 1 year, if you find that the skin is not looking good, send it to the pediatrician.
Okay.
Otherwise, 5 years is all right.
Okay, fine. Thank you. So, Somo, a 1-year-old child present with sudden locking of right thumb. Do you need to send this to an orthopedic urgently?
So this is called trigger thumb, or this is not a congenital trigger thumb. This is developmental trigger thumb, because sometimes you see at present there is at birth there is nothing. Usually appears after 6 to 8 months of age, and there is something called locking. This triggering action sometimes locked permanently. Usually we advise orthopedic surgeons, pediatric ortho, we advise to do a passive stretching up to 1.5 years of age. If it is not corrected by 1.5 years of age, we will go for release of the trigger thumb. In adult cases, we have some use of needle technique or use of steroid, but in pediatric, there is no role of needle or steroid. We just go for open release after 1.5 years of age.
Okay, so we are heading most probably to the last surgical question. So after a few months, mother notices an inguinal swelling when the child cries. The region of the scrotum also looks a little larger. Parthoda, in short, inguinal hernia, hydrocele, and absent testis.
Number 1 is, if it's an inguinal hernia, it should be taken as a semi-emergency. Tell the parents the chances of obstruction is there, and then the whole operation becomes an emergency with a lot of problem. Otherwise, it's actually a daycare surgery. If it is a hydrocele, again, wait till 2.5 years. Usually it resolves. If it doesn't, then only we do an inguinal herniatomy, because the operation is the same. The condition is due to the patent processus vaginalis. Now, if there is an empty scrotum, as you said, then always, if say the child is, nowadays we operate for an empty scrotum at 6 months age. Now, If you have an empty scrotum, look and feel for the testis in the inguinal region if you can. If you can't, just do an ultrasound of the inguinal region, and if the ultrasound can tell you that the testis is just deep to the deep inguinal ring, we do the operation at 6 months through laparoscopic assisted orchidopexy. But once you have a report from the sonologist that the right testis is all right, left testis cannot be seen, advised MRI or CT scan and angio and whatever, just ignore that report. Once you have a report that the left testis is not seen, sit with the parents that I do, that listen, this is the normal road for the testis to come down. The best thing that we would do is a laparoscopy and find out at which point it has stuck, or at which point maybe, very rarely, intra-abdominal torsion would make that part testis smaller. In that case, whether you take it out or not, and very, very, very rarely, there may not be any testis. So an empty scrotum, you must work till 6 months. Well, you may wait, but those which come down, which were not palpated at birth, 30% or 40% of them come down, but at birth, actually, they are felt in the inguinal region. Okay?
Thank you.
Treatment options is now just surgery. Now, when you do a laparoscopic assisted orchidopexy, if it is too high up, we may do a 2-stage, or if it is more or less around in the pelvic brim, we do it at 1 stage.
Just because we are in a lack of time, Parthoda arekta bolo jeta emergency surgical, that is torsion, acute torsion testis in a 5-year-old or a 10-year-old. What do you do?
Just take the, if you have a Doppler and Doppler is confirmed, take the patient to the operation theater if it is within 6 hours. Otherwise, it's not an emergency because you can't salvage the testis anyway. But once you have it within the right time, go ahead, a scrotal approach, take the testis out, see where the torsion is. Usually it's an extravaginal, detoss it, wait for some time, if necessary, bisect the testis, and then see whether it is viable or not. Even if you have even 10% chance of viability, you better put it back. And there is a controversy these days. When we were students and trainees, we were said that do a scrotal orchidopexy on the other side so that that doesn't get tossed. But it has been found over the years that these kind of torsion, which is extravaginal, is usually not necessarily bilateral. So there is a debate going on whether you do a scrotal orchidopexy on the unaffected side.
So the most important message Parthoda has conveyed, all pediatricians be very, very careful whenever you see a case or suspect a case of torsion testis. Please document the time from the time the parents have noticed and the patient has come to your chamber. We have seen, I have documented and I have already studied 2 cases, medical legal cases, where the time was not documented. And the parents later alleged that due to the delay of the pediatrician, the child lost my prestige and the pediatrician had to pay a lump sum amount of money as compensation. So this 6 hours is very important. If you document it well, you'll be out of trouble. Thank you, Parthoda. That would be the last surgical questions we can take. And
so
last question, Somo, we'll wrap it up after this. Baby born with hyperextended knee, is it an emergency?
I previously said that CTV or congenital talipes equinovarus is not an emergency. It can be dealt after discharge. But if there is a patient has a knee reversed, opposite side, majority of the cases, if it's idiopathic, it can be reduced completely. So this should not be delayed. Sometimes we have a syndromic variety that cannot be reduced. For that, we need a surgery. But if it's an idiopathic variety of CTK, that can be reduced if the patient can be presented to the pediatric orthosurgeon early, and that can be cured completely. But if you cannot reduce it, even the pediatrician can also try it, because what is the way of reducing? You just don't bend it. If you just bend it, This will cause distal femur fracture. The principle is you just pull it and then bend it. If you just pull it and then bend, it can reduce. But if it is not reducing, don't force it repeatedly. It will cause distal femur fracture. Better to send to pediatric orthopedic surgeon earliest.
So I think with these legends, the upcoming one and the legends, we have played this game well over 1.5 hours, and probably we have won. So this will not be the end of the legends, but we have tried it to make it user friendly, as we say in today's terms, user friendly for office pediatricians who often complain that the academic bodies talk of bigger things, but do not give us something to take back to our chambers. I think our initiative and the beautiful deliberations by Parthoda, Somu and Mitrojit Da has helped some pediatricians in some way. So thank you all for waiting for such a long time and giving us time out of your busy schedules. So WBAP has
Okay.
legends have started. We'll be back next month. Thank you so much.
Thank you.
Thank you so much. Good night. Take care.
Hello. 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 Are we there?
Yes, yes.
It was really a very beautiful academic session with phenomenon like Professor Parthapratim Gupta and three rather budding legendary doctors, pediatricians like the orthopedician, Dr. Shoma Paik, pediatric surgeon, Associate Professor Dr. Mitrojit Mullik, and our dear Dr. Swamik Basu, who has done an excellent moderation today. We are going to have the 8th legends very soon, and it would be on pediatric eye, pediatric ENT, and pediatric dentistry, and it will be moderated by Dr. Shomik Ghosh, an EB member of our WBAP. So I would like to call upon our president, Dr. Shushmita Banerjee, to end the program today. Being very nice of you to be here. Thank you. Shushmita Di, can you please take over?
Yes, I think it was an excellent program. Many learning points for all of us. Very big thank you, Parthoda, Dr. Paik, and Dr. Mullik, and biggest thank you, Shomik, for conducting this beautifully. I really hope that the audience enjoyed this as much as we did. Thank you. Good night. See you all soon.
Thank you.
Thank you
Good
so
night.
much.
Take
Thank you.
care.
Good night.